I'm delighted to welcome Dame Sally Davies, the Chief Medical Officer of England and the Chief Medical Advisor to the British Government, to Melbourne. I believe you've just got off a plane and probably struggling with a bit of jet lag, so hopefully we'll have a really interesting conversation. We're going to focus on antimicrobial resistance. I'd also like to ask you a couple of questions about the current status of the health system in the UK and your reflections on what we have here in Australia and in Victoria. And also I'd like to hear a little bit about your career and your background and where you've come from and what's brought you to be where you are today.
That's a big agenda, but it's a pleasure to be here. Thank you.
So Dame Sally, you're here talking about antimicrobial resistance. In a lot of interviews you've talked about the post-antimicrobial apocalypse. What do you describe that as? How does that look to you? What's the challenge we're actually facing?
Well, when I talk about antimicrobial resistance, in effect, it's infections that don't respond to drugs, which has happened because there's been a mutation, it's natural selection. Indeed, Fleming predicted it would happen. And essentially, drug-resistant infections are rising steadily. And they're rising because we don't prevent infections well enough, because bugs, whether they're bacteria, viruses, fungi, malaria, parasites, whatever, keep building resistance. And we've not got good diagnostics that are speedy. We've not got vaccines that prevent everything. And we've not had any new classes of antibiotics come into use. We've had reformulations and better ways of using them, but no new ones since the late 80s. So they've had some decades to get used to what we use to kill them.
So what's the outcome of getting to a point where we actually can't fight with the current weapons that we have? What will the world look like? What does that actually mean in practical terms?
So at the moment, probably about 7% of people in our countries die of infections, but that's terminal cancer with an infection or something usually. And that'll go up to 40% or more. And it'll be not just, oh, you've got cancer, which makes you prone to an infection and we can't treat it. It'll be things like scratches on the face that then introduce an infection into the blood, and you die of that infection.
So what are we doing to counter this? I know you've done an awful lot of work raising the awareness of the problem, and I know that the UK government has invested fairly significant funds in addressing the issue. But what are we actually doing? What does the work look like?
Well, the world's getting steadily worse. Empty pipeline of new drugs. The drug-resistant infections death rate going up year on year, so it's at least 700,000 die every year of drug-resistant infections. If that was something else that they were dying of, we'd hear about it, wouldn't we? And that will just go higher. In Britain, because we've been working at it, we're reducing our use of antibiotics. Looking at the data in Australia, antibiotic use is high, much higher than we have in Britain, and going steadily upwards. So though you have a good strategy, you're still overusing antibiotics. And we've put in place behavioural modifications, much more education, incentives in funding to try and reduce prescribing. And that's in the human sector, let alone what we're doing in agriculture. So our chicken industry over the last 4 years has taken 71% of antibiotics out and raised protein production by 11%. So we're working in every one of the One Health areas to try and reduce antibiotic use and prevent infections.
So can we talk about the use in agriculture for a moment, because I think it's something that probably most people don't really understand, that a lot of this comes from the massive use of antibiotics in agriculture, particularly rearing of animals, obviously. And how have you been able to make that change in industry when profit is the bottom line and evidence doesn't always rank particularly highly in profit-based decisions?
Well, most human deaths are caused by overuse in the human sector at this point, but overuse in the animal sector contributes to resistance that then can impact us. So across the world, over 70% of antibiotics are used in animals, of which about 3/4 is used for growth promotion. In Europe, that's been against the law since 2006, so we have reduced steadily. But the Americans have only stopped since January 2017 the use of critical antibiotics. So you can see that people remain using too much. So how do you reduce it if it isn't by law? There's education of farmers and animal husbandry, increasing vaccinations, things like that. But very importantly are two drivers that are outside the health system. One is consumers. So the Consumer Association in the United States published a report called The Chain, and they grade fast food and multi-restaurant chains by the meat they serve and the antibiotic use of the meat producers. So that has had a dramatic impact because you've got Subway quite close to the top, because they don't buy chicken, beef or pork from people who use antibiotics for growth promotion. So consumer pull is important, and we're getting some of that now in Britain building up. And investor pull can be very important. I was at an investors conference talking to 300 investors a couple of months ago saying, you should not invest in companies that misuse antibiotics. That is not part of your social responsibility. So I think you can get at it in all sorts of ways.
Multifactorial.
Yeah.
So back to the work that you're doing. I read recently that you were sort of spearheading a campaign, a $10 million campaign out of the UK government to encourage researchers to do work on new antibiotics and resistant strains. What's the thinking behind that, engaging the research community? How critical is that, and what other ways are you going about it?
We need new science, we need new innovation. In prevention and in treatment. And actually, our government over the last 4 or 5 years has spent more than £367 million on research, some of it through our research councils, who've been doing some beautiful cross-disciplinary work, a lot around behaviour as well, but quite a bit, 50 million in an AMR innovation fund, and so we've just announced a call with Canada for different ways of either improving growth without antibiotics in animal husbandry or vaccines, for instance, for fish farming, so doing that, but we're also partnered with China, spending £22.5 million on looking at their traditional medicines and have they got new antibiotics and antibacterials and things. So we're funding in all sorts of areas.
Is one of the issues that antibiotics are not the sexy new thing, that researchers, that drug companies aren't interested, or is there something deeper? Why haven't we had new antibiotics or new classes of antibiotics since the 80s? What's the root of that?
So we've got two problems. The first is the low-hanging fruit was taken by the late 80s. The second is a market failure, and it's an economic market failure. We pay very little for antibiotics. We don't expect to pay much, and if you look at the price of a course of antibiotics, it's in terms of pounds as compared with double-digit thousands of pounds for a new cancer drug or something. So how do you change that and rectify it? Indeed, it's become so bad that some of the old antibiotics, well off patent, are difficult to get hold of because all the companies have consolidated because there's no money in it. Which
is a sort of a definition of a wicked problem, really. And is the work that the UK government has done to encourage people to move back into this area, is it enough? What do we need to do to change that tide? Is there more that we could do? I'm sure there must be.
There has to be, because we haven't got there yet. I'm very worried about it. So I asked our Prime Minister, the former one, Cameron, to commission an independent review from a well-known economist, and Jim O'Neill did it. He used to be the chief economist at Goldman Sachs, and he laid out very beautifully all the problems and the need to de-link the research costs in finding targets and new drugs from volume of sales and the price, so that we would get new antibiotics and antimicrobials, but we could look after them, steward them, be very careful with them, and the companies would get their money either as prizes or some other market entry reward, so that we didn't have to get them getting money by piling them high and selling them cheap, which drives more resistance. The Americans have just a couple of weeks ago announced that they're, and it's cross-party and cross-house, that they're going to try out in this area a transferable patent voucher for 12 months. And that might crack it and do it. But in Europe, we need to do more. One of
the challenges that you've talked about is prescribing of antibiotics and also people being prescribed, certainly probably more commonly in developing countries, too low a level of antibiotics, people not finishing their course. What's the role of individual GPs, clinicians, pharmacists in addressing this problem?
So if you don't want resistance, you want to give a good dose of a drug for long enough to kill the bug. So underdosing, either because they're counterfeit drugs so that there's only a trace of the antibiotic in it, and antibiotics are the most common counterfeit drug across the world, or because in poor countries people can only buy 1 or 2 days so that they don't get long enough to kill them, drives more resistance. So there's that problem. And then there's the problem that in Britain we know that about 1 in 5 antibiotic prescriptions in the community is not actually needed. And I can tell you that the research in Australia suggests it's probably higher than that, the overprescription levels. We need to use antibiotics when they're needed. We should not use them when they're not.
So it's part of the problem there that the general public think an antibiotic will fix whatever is wrong with them. I've got a cold, an antibiotic will fix it. And clinicians don't say no.
Absolutely, and because viruses get better on their own, if you take an antibiotic, how do you know it wasn't the antibiotic? And we did some research. Actually, it was kind of more market research, because we were designing the company was designing a marketing campaign which ended up with singing antibiotics, saying, "Look after us," it's a great one. But what they discovered was that patients like having antibiotics because it validates the fact they're ill. And they'd ring up and say, "You see, I said I was ill, I've got antibiotics," to work or to their friends. So what we tried, and it seemed to work very well, so we're rolling it out a bit further and evaluating it, is prescription sheets that weren't for antibiotics and drugs. They were, yes, you are ill, and the name at the top, and this is what the illness is, it's a viral and it's in your throat, and this is what I advise you to do, and take some paracetamol, drink plenty of fluids, rest, things like that. And it will take a few days to get better, signed by the GP, tear it off, give it to them, and then the patients like it. Yes. So that you validated it and they can ring up and say, "I got a prescription."
So you've actually got a bit of behaviour change going on, and hopefully a little bit of confidence for the employer that they actually were ill, even though they didn't get antibiotics.
Yes.
You obviously mentioned Fleming and the groundbreaking work done centuries ago in the development of antibiotics. Where are the really exciting pieces of work being done today? Who are the leaders in this space? Who are the people you'd call out? Where's the really great work happening?
Well, I wish I could say a whole list of names, and I'd love to give you multiple drug companies, but many have left this field. I am proud that GSK have got an antibiotic that looks as if it's going to be very successful for gram-negatives. Tasis has got one that looks good for gonorrhea. J&J have got one that looks very good for multi-drug resistance TB. But there I am saying the bug, the drug and the company, and there aren't many of them. We've got university departments, I think, coming back to strength. The Netherlands has never lost it, and we're beginning to get some, and clearly in America. But we need not just the scientists working on the bugs, we need to think about vaccines for fish farming, because most fish farming, they just tip antibiotics into the feed. We need people doing work on alternative ways of doing growth promotion, and is it with pre-digested food, is it with probiotics? There are all sorts of different approaches. And so it's going to take the whole spread of researchers, including behavioural economists, working with patients, doctors, vets, and everyone.
So one of the challenges that we have in Victoria that is replicated across the developed world is an issue around demand management, an issue around certainly our acute health systems being massively over capacity in most places. If what you're talking about comes true, that is only going to get worse. What do hospital leaders in Victoria, but also elsewhere, what do they do to manage that issue? How do we ensure that this is taken seriously and that challenge around demand management, which this will inevitably make more difficult, is brought to the surface? How do we ensure people take that really seriously?
Well, it's surprising if the hospitals aren't, because there's quite a bit of data now about how if you have drug-resistant infections, it increases the morbidity, mortality, and therefore cost. In Britain, talk about it doubles the length of stay and doubles the mortality and doubles the cost. So it's in everyone's interests to reduce the incidence of drug-resistant infections. You have to start with knowing what you've got and really good surveillance. We have national point prevalence studies every year. That gives us a very good picture. I don't know whether you have that and whether the hospitals have good surveillance. But then, attached to the surveillance, you've got to have very careful antibiotic stewardship programs. Are people using antibiotics when they're needed? Are they using the right antibiotics? Ideally, in your hospitals, if you've got electronic prescribing, at 36 to 48 hours, the initial prescription of a broad-spectrum antibiotic will be stopped, and a flag will come up and say, now you have to find out if the patient did grow anything from their blood cultures or urine, and change to the right antibiotic, because a lot of overuse in hospitals is just continuation of antibiotics, laziness. They never checked, they never stopped. So there's all of that. And then we find in Britain, we seem to have to, every 5 to 10 years, re-educate the health service totally on hand washing and how to do it obsessionally to reduce MRSA and general infections. So it's, as always, complex, whole system and multiple approaches.
It's interesting you talk about hand washing, because of course that's an obsession for us as well, and as it should be. One of the things that has happened in recent years is the banning of certain types of antibacterial hand washes in the United States, and a push to do the same in other parts of the world, with evidence showing that they're not necessarily any more effective at washing
than good old soap and water, yeah.
Exactly. But that they might be adding to the antimicrobial resistance issue. What's your view on?
Well, they may be. I would prefer soap and water because it works, and why take the risks if you don't need to? Alcohol's pretty useful too.
And we still use that, obviously, extensively in hospitals. What would you say to the Victorian or Australian governments if you were trying to sell to them the importance of antimicrobial resistance and the response to it? What are the key actions you would suggest governments should take based on your experience in the UK and also with the WHO? What should they be doing?
So I'd talk about the cost to them already and how it's going to get worse. And then I would push hand washing and infection prevention and control. Are children going through their vaccination programs effectively? Because, and other people at risk. And it may be, say, the pneumococcal vaccine, which saves pneumococcal infections, so you don't need treatment with antibiotics, or the flu vaccines, because if you don't get flu, you're less likely to get a superimposed infection. But it is important we deal with it. It's not just the cost. We risk losing modern medicine, cancer treatments, replacement, joints, caesarean sections, all need vast amounts of antibiotics to prevent infections or treat them. So they do need to think about it and have plans. And you can get into the behavioural things like we have. So one of the experiments we tried was a letter to half of the top 20% of general practice prescribers, just saying from me to them, you're in the top 20% of prescribers. I did get a postbag of irate doctors, but overall, prescribing came down. We've tried financial incentives to hospitals, and that's been quite successful. So there are different ways of approaching it, and I would try all of them.
Absolutely. One of the things you talk about a lot is the importance of evidence-basing treatment, models of care, policy. One of the reflections that I would have about trying to ingrain that idea of evidence-based once it leaves academia and moves into the public policy frame is that often your decision makers will run in the opposite direction as soon as they hear that someone's going to explain what the evidence says in detail. And I talk to a lot of academics who get very frustrated by the fact that the policymakers don't just want to lap up the research that they've done and act on it. How do you, in your role working with senior politicians, get past it's evidence-based to this is what the evidence means, this is what you should do about it, without them running in the other direction?
Well, I think the problem for academics is that they're always interested in the latest study, either that they've done or someone else has, whereas I think if you want to change policy, it's rarely an individual study, it's usually a meta-analysis and a review. So I'd like to know that I'm basing it on a body of evidence first, but you have to frame things to policymakers and politicians in a way that they can understand. And so it's not banging on about, look, I've done this and this is what it shows. It's, you have a problem and this is the way to approach it, which is backed up by evidence. So I look at it as a reframing through to solve a problem they've got.
Yeah, it's a really interesting way of framing it because we are often approached by people who work in universities or academia who say, nobody will listen. I've got this great study and nobody will listen. Why will they not listen? And actually it's about the language. It's about getting to a joint place of understanding so that you understand what that policymaker's problem actually is. Because it might be slightly different to the piece of work you've done.
It generally is, yes. And some academics get it and very many don't. One of the roles I have is actually in management terms of being a boundary spanner between politics, policy and academia. And trying to bridge that, and it is about framing it and seeing what the problems are and saying to the academic, it may have taken you 3 years or 5 years or 10 years, but actually it's only 2 sentences. Yeah. This is what we know at this point. And the need to accept 2 other things. One, that science does shift over time as we develop more evidence from one side, and the other side is that politicians, democratically elected, have a different sort of knowledge and evidence to call on, and that therefore what you end up with is a social construct which brings it all together. And people who don't understand that social construct actually bash a brick wall.
Absolutely, because at the end of the day they have their mandate and we have to work in with that. One of the other types of boundaries that you span, to use your term, are the international boundaries covered by the WHO and the UN. And can you talk a little bit about the work that you've done on the international stage around antimicrobial resistance, your work with the WHO, your work with the United Nations, and how that's developing, and how it differs from the work you might do within the UK in your day-to-day job?
So part of my role is to be the UK's person on the WHO's executive board. And I felt that we needed to take antimicrobial resistance to the board and the World Health Assembly and get a resolution to do something about it. But when I started to do that, I was told, but that won't make any difference, we've had a few. So I said, all right, what we need to do is get the World Health Assembly to agree a global action plan so that every country would go and build its national action plans that would all come together in a global action plan. And I persuaded the former Director General to get me to chair a strategic technical advisory group to help them develop that. But in order to get that to happen, I discovered it wasn't just a group of doctors deciding, it gets into politics. So I am the Chief Medical Officer, not for the Department of Health, but for the UK government. So I went to our Foreign Office and said, I need your help, I need diplomacy. So then the diplomats came into the subject and started to work with other countries. The Netherlands and Sweden were particularly supportive and helpful. Chris Bagley, your former Chief Medical Officer, played a key role. And so that then brought together a coalition of willing countries. Having done that, we got the Global Action Plan through that. Our ambassador in Rome to the Food and Agriculture Organization got it through there, but the same countries came in and helped. And then we got it through the Organization for Animal Health. Then we sat down as countries and said, so yes, but it's One Health, and actually we don't think that WHO, FAO are doing enough, and environment's involved. So how do we get a greater focus? And I said, let's go to the UN and have a high-level meeting. So then, again, we worked as a coalition of countries to take it to the UN. And our diplomats played a massive role, both out of our mission in New York, but also Geneva, working into different countries. And our Foreign Office does a wonderful job on this, and have been joined by our aid agency, DFID, who also now put AMR into all their major grants and their work with low and middle income countries. So it's become a priority in our foreign policy for us to work with other countries to push it in country and at the global level. And of course that was helped because I asked for it to go onto the government's risk register, and we went through that process. So you have pandemic flu at the top of the risk register, then you have terrorism and AMR. So it's a priority for the whole of government.
It's interesting talking about international cooperation on health, because there was recently a situation around breastfeeding, with the WHO having an interesting political situation arise around the support for breastfeeding versus use of formula when it's not necessary, and commentators saying if you can't get cooperation on health internationally, how can you get cooperation on anything else? So do you feel that health is becoming on the international stage maybe more politicized, more interest based, or is it actually improving, or is it the same as it's always been?
I think we're using it for global diplomacy more and more, and we're seeing, for instance, Germany begin to play a bigger role in global health. We're seeing China, through the Belt and Road Initiative, building infrastructure to support health. So I think it's going up the agenda of global diplomacy. Let us hope that improves health outcomes.
I want to ask you a couple of questions about your reflections on the health system we have today versus what we might have had in the past. Obviously, this year is the 70th anniversary of the National Health Service. For Australians, the love British people have for the NHS is a little bit confusing. I know a lot of Australians were very surprised to see the NHS figure so heavily in the opening ceremony of the Olympics. There were certainly a lot of water cooler conversations about that the next day. But to English people, that wasn't surprising at all. What are your reflections on the NHS as it stands today, 70 years on, versus maybe what it once was? What's the good, the bad, and the ugly?
It's the nation's religion, we say now. The good is pretty good care everywhere across the country, free at the point of access. And I'm proud of the fact that it's pretty good. And I think we've got some fabulous, excellent. And I think we've steadily brought the bottom up, but always we're uncovering other problems. I don't think we're unique as a nation in that. But no one's out of pocket yet. Because of NICE, we have cost-effective, modern services. So I'm proud of it. But we have a problem that across the world, the cost of delivering health services is going up and up, partly because of the demographic changes, an aging population, and with that goes increasing multimorbidity, let alone the pharmaceutical companies lobbing over the fence to us some very expensive drugs for rare diseases, cancer, etc. And so the cost seems to be running at a kind of 4% inflation, and we don't have that money. So how do we make what we've got more productive is the big question. We were very lucky. NHS was 70 last week, and the Prime Minister announced a big new gift, a birthday present of significant new funding, which will rise to 20 billion extra a year. It's a lot of money. Yeah. But actually, people wanted more, and they would have spent more. But you can't just let it go up and up and up. So we need a national conversation about this. What do you expect of the health service? What is reasonable? I think if you compare us to the Scandinavian countries, we've got less individual resilience around health. People go for more minor things. Meanwhile, we're recognising more and more the demand and need for mental health, ill health services, and so we've got increasing costs there. So, inexorable demand, a nice birthday present, but how are we going to square the circle?
Yeah, and one of the challenges that we would have here, just as much as you do, is the increasing and probably over-reliance on acute health services and the underutilisation, not just of primary care, but of community health, of home-based care solutions, aged care, and certainly massive underfunding of things like mental health. Very little attention on prevention. And we would say that the solution is an integrated system. Do you think that you have an integrated system or a version of it in the UK?
No, we don't. The Lansley reforms of 2012 actually took that backwards. So we're now looking at ways round that Act of Parliament to try and integrate. And there are two sorts. There's kind of the vertical integration of community, primary and acute and very specialist. And there's geographical integration. And then, of course, we're interested in how do we integrate social care with the health service. So integration, when we talk about it, I often have to ask people what their definition is in a conversation. But clearly, the more we can bring it all together, the more patient-centric it will be. I would prefer to be looked after by someone who could deal with all my different chronic diseases rather than keep going to see different people.
And one of the things that we've done a lot of in Australia is marketisation of formerly public services. So disability services, we have a wonderful innovation called the National Disability Insurance Scheme, which is an insurance-based funding model for people with disabilities. What it is challenged with is turning a system that may once have been not perfect but was relatively integrated into one that's based on individual organisations delivering specific things. So the integration becomes more difficult. We have that situation in some places in our mental health industry and alcohol and drug response. So integration becomes harder in a marketised environment. What's your reflection of the role, I suppose, that the private sector, the not-for-profit sector can play in supporting or maybe making worse that integration picture?
Well, if you'd asked me when I was young, I thought public services should be provided by the public sector, but I can see that the private sector can, by bringing competition, but also bringing different practices, management practices, offer an alternative. But what of course has happened quite often is that they've creamed off the easy and the cheap stuff and left the complex stuff for the health service. So while no longer against it philosophically, it does mean that the hospitals, kind of average cost has gone up, so they compare badly on terms of cost. But that may not be or that may be because you're not comparing like with like. So I think it's quite difficult. Will we get rid of that? No, I doubt it, because both political parties from both sides, in fact it really started with the Labour Party, have gone for this kind of competition to try and increase both the quality of care but the cost of care.
What I would like to talk a little bit about is your background and what you've done to get to where you are today. You started out as a haematologist, you're still a haematologist, renowned expert in sickle cell anemia, and what was it that drew you to haematology in the first place?
Actually, I tried haematology because I was doing paediatrics, which I enjoyed, but two things: it wasn't compatible with easy married life because of the on-call, and it was very general. So I thought I'd try haematology, and then I ended up loving it and became a haematologist. My career is one of serendipity. It is not planned at all. I never meant to go and run research for the nation, and I never expected to be CMO.
And what would you say to people who are looking at your career and saying, that's what I want to be a leader in the health system? People who are maybe thinking that it's too hard. Clinical leaders often find it very difficult to break out of the clinical leadership roles into the system leadership roles. What advice would you give to people who are looking at that kind of career?
I think there are a number of things. One, while there are people who are very focused and know exactly where they want to go, for most of us the best thing is to enjoy the journey. I've loved everything I've done, so the fact that I kept going up is a bonus, because then I got stimulated and met different people and different challenges, which I perpetually enjoy. But when offered the opportunity, take it and grow with it. I benefited from some really superb management and leadership training, which really I do think is helpful. The idea that we all come fully formed and are able to do it, well, some people are, but I needed help. And I'm not proud, it made a big difference. And then being prepared to put yourself in other people's shoes. So I was talking about handling politicians and reframing issues, thinking about management from the manager's perspective, not just the clinicians. We sit between those who do just looking after patients and those who are trying to manage the system and the money, the managers. Trying to think about it from their perspective and thinking what you can bring.
You are and this seems to be a big factor in all of your biographies and all of the interviews where people describe you as the first woman chief medical officer. What would you say is the track we need to take to ensure that that's not special anymore? What do you think in 10 years from now, what have we got to do to make sure that the fact that you are the first woman, which is an incredible achievement, is not that surprising anymore? Because at the moment it's fantastic, but at the same time it's sort of a bit depressing.
Yeah, we shouldn't have to celebrate it, should we?
No.
Well, I do quite a lot of mentoring. I find it very interesting that the people I looked up to and that mentored me were all men, but I'm told many women want women mentors. They want to see that the women can do it, so they've got something to follow. So I do quite a bit of mentoring, and I think we've got to do that. I think, there's quite a lot of literature on this, so I'm going to talk in generalisations, and I absolutely accept some men are like this and some women are different. But women often won't apply for something if they don't think they can do 80% of the job, whereas men will apply if they think they can do 30%. So how do you bring the women out? And there's an evidence-based on how you write job descriptions in order to attract women to apply and things. And we need to learn from all of that. But it is also about just pointing to women and say, come on, you can do this, give it a go, and giving them the space to try.
Is it a friendlier environment for women, the health system in the UK, now than it may have been when you first started out?
Ooh, yes, it's dramatically better. Is it good enough? No.
Yeah. And there's still a way to go.
Yes.
Because obviously with the Me Too movement and the focus on gender equity and all of the rest of that, which is incredibly important. And in Victoria, the government put an enormous amount of investment into addressing family violence, which is a scourge of our times. I think the national conversation is still based on rectifying past wrongs, and I think your reflections on how we might move that into the future, the more positively framed, how do we actually bring about gender equity rather than just talking about it?
So you can do some structurally. Whether it's numbers on boards and numbers at different levels and positive affirmative action, positive discrimination. One of the things I did was I tied shortlisting hospital or medical school partnerships for a very big pot of research money to having an Athena Swan Award, which is a charter mark for women and being sympathetic to women. And that raised a lot of angst among the medical schools and many of the men. In fact, I got some of the rudest letters and phone calls I've ever had in my life because of that.
A mark of success.
Well, yes, and I'm not for turning when I think I'm doing the right thing, so I don't know why they bothered, but they did. And it was the men that did it. So you can do structural things, but then you've got to do the kind of bottom-up cultural stuff. So I was very interested to hear here about the ethos system being put in place in some of the hospitals, a cultural change and being able to report and looking at it.
Yeah. What advice would you give to yourself when you were starting out? If you could talk to your younger self now, what would you say? Be braver. I have suffered from the imposter syndrome, just like many women on the way up. And some men. Yeah. No, I'm not anti-men, far from it. Be braver. Learn, get the self-confidence earlier, or learn to be assertive, not aggressive. I was aggressive for many years and had to make that shift. And have fun. Whenever possible. What's your biggest achievement to date? Whew. My husband
remarked not long ago that I was a campaigner who ended up in government. So I've campaigned fairly successfully on 3 issues. The first was about sickle cell disease. The second was to get the National Institute for Health Research, which was my idea, set up. I ran it for 10 years, got a budget of over £1 billion a year to spend. And the third is the global work I do on drug-resistant infections, AMR.
So when you're talking to your children, what advice do you give them? What do you want them to follow are they following in your footsteps?
I remember walking into the school of my older daughter in her final year of school to be greeted by a mother. "You've become famous throughout the whole year." I said, "Me? Why?" And she said, "Because apparently you say your daughters should do whatever they want to, because then they'll do it well." And that is my advice. Do whatever you want to, because then you'll enjoy it and you'll do well. They should not live out my fantasies. Many children are forced to live out their parents' fantasies. I live my fantasies. They live their lives. They should do what they want.
Just one final question. You mentioned earlier the importance of mentoring. We think mentoring is incredibly important, particularly for people in senior positions, which can often be incredibly lonely. But also role models. So who were some of your greatest role models that you looked up to, either from close by or from a distance?
Professor Sir David Weatherall in haemoglobinopathies, wonderful, FRS, wrote and edited the Oxford textbook of medicine, superb physician and had time for people, wonderful. One of my mentors who helped shape me was Bob Williamson here in Melbourne, who told me I could do it, I should stick with it, and supported me. So they were all men, because there weren't many women.
But that's changing, and hopefully you're a role model, I'm sure, to many people.
I'm told I am.
Across the UK and across the world. Thank you very much for spending this time with us this morning. I hope you enjoy the rest of your time in Australia, and I hope very much to be able to talk to you again, because I could talk to you all day.
Thank you. I look forward to returning.
Thank you.